Hello, everyone. Thank you for taking the opportunity to watch this webinar. In this webinar, we're going to be talking with three professionals who work for some of our state's community mental health organizations. We've got Dr. Sean Fields from Summit Point, Jennifer Kimmel from Genesee Health System, and the lovely Sojourner Jones from Detroit Wayne Integrated Health Network. And today we're going to be talking specifically about the effects that assisted outpatient treatment has had directly on emergency department, specifically patterns of use, frequency of use. So to get started, Jenny, I would love to hear how have you seen clients on assisted outpatient treatment orders change in regard to their ED use?
Yeah, so when our consumers are put on an AOT and they have had a 95.5% compliance rate for our year two. And what that means is that of those consumers that are put on an AOT, most of them are following their outpatient treatment plan and not needing their order to be violated, getting a pickup and being brought back to the hospital. So I think that has substantially reduced the number of consumers going back to the hospital and utilizing the ED.
95.5%. That's almost otherworldly. That's amazing. Congratulations. That's outstanding news. Sojo, what would you add? What have you seen? What's changing?
I think having the conversation is for us is tremendous. We have a long way to go to get to Genesee County, but that's our goal. And so we are having ongoing communications with the EDs, with the ED directors, trying to coordinate care from that level and get members served in the ED as opposed to a higher level of care. We're not quite there. It's a new process for a lot of people. And so we're just continuing to have these ongoing conversations, reinforcing what the statute says in terms of the burden of continuity of care, and inviting them to stakeholder meetings so that they can have conversations with the judge in the probate court. We just had our grand opening of our behavioral health unit. And so I think with those collaborations, the ongoing communications, Jenny, you probably don't know, I do this a lot. I'm like, well, in Genesee County, they're doing this and that's our goal. And so giving them something to read on their own, to gain knowledge from, I hate to say buy-in, but that's pretty much what it is. They have to see that this is going to make a difference. And so for us in Wayne County, whatever that is, that carrot, that light bulb that's needed, that's what we're in the process of doing. And so we have a long way to go, but that's a good thing. And as long as people are open to the change and can see that this is something positive, then that's just what we have to do at this time.
Right. Dr. Field.
So I do envy the 96% compliance. We are not quite there, but we are hovering in the 60 to 70% area. Obviously, repeated engagement increases that for us. What I will say, for customers that are engaging and participating fully, we do see a reduction in how they go to the ED or how often they're going to the ED. But with that large percentage still needing a lot of support and engagement early on to get them participating, what we're starting to see is a difference in how they use the ED. So it's intentional that they're engaging with that program through us doing orders and pickups and working with the court. So it's more of a proactive visit in use of the ED as opposed to a wait until the crisis gets to that level and they end up there through law enforcement finding in the community or getting calls. So I think that's the biggest change that we've seen in terms of how we've been able to work with the ED is that we're proactive and how the ED is part of that continuum and less incidental. So that's been really nice in building that continuum with the hospitals and law enforcement to understand that relationship. I think the initial idea was, oh, once there's an AOT, we'll never see him back in the ED, and that's just not true. But the way that they go to the ED is different. So I think we've found that in particular has been very valuable for the customer's experience at the ED, as well as the relationship between us as the CMH and the department itself and receiving those customers.
It's a really good point that it may not prevent ED use, especially when ED use is necessary or appropriate, but changing that format, especially I know as someone who works in an emergency department, not seeing them there and essentially boarding for days on end, waiting when we could have avoided the crisis in the first place. Which I guess kind of brings me to the second question. I'll stay with you, Dr. Field. Have you heard anything from EDs regarding the effects of your AOT program? Are there certain familiar faces maybe that they've commented, oh, we're glad to know they're still around and they're doing better. We haven't seen them, as often as we used to.
Yeah, I think what we're hearing from the ED staff primarily is that they're not feeling caught off guard by individuals that are visiting, or they feel relief if the customer does show up, that there's a pathway to support them. I think the biggest thing that we've got feedback from the ED on is when someone comes in with an order, they know who to reach out to. They know how to coordinate that customer to potentially divert as opposed to going into an inpatient setting. And they find that those pathways are accessible as opposed to, having to figure out who do I reach out to? How do I do a referral? Customers in those situations, the ED's stories generally are, we know what we're doing with those individuals and how we can support them, which has been really nice to hear from the ED staff, as well as our team being able to engage in that relationship as opposed to finding out that they were at an ED a week later, having that really proactive relationship between the two programs.
Ooh, interesting. Sojourner, how about from Detroit Wayne's perspective? Are there EDs where you're hearing anything positive, anything similar to what Dr. Field described in Calhoun County?
I would like to say yes, but unfortunately, no. However, one of the things, and I explained to the emergency department, and even with our service providers, our members come to the ED because they know the staff. They have a relationship with the ED staff, as opposed to having that relationship with the therapist and the CMH provider. And so, having those conversations, making sure that the ED know who to contact at the CMH provider for a member that's on an AOT has been, it's been monumental, because the ED staff really want to be a support, but their support is limited because they don't have to see or shouldn't see the person as often as they do, especially for crisis, when they know that there's a CMH provider. And so more of our, with the EDs, some of our challenges is that, they like, well, we called the CRIS, they weren't responsive, and so part of my role is trying to get them to be more responsive. Even doing a warm handoff from the ED to the CMH provider is one of the goals that we've set right now. Like I said, we have a long way to go, but still trying to do some interventions and making sure that continuity and connection of care. Even if the member can't do a warm handoff to their CMH provider, then what other services are available? Can we send a crisis stabilization unit to the home? Something to make sure that the member is connected. I believe that is the biggest piece about AOT that I really like, is making sure that if that member needs a touch point, they know where to go and who to go, and that provider in person is going to be there. The worst thing is to have a resources, and when you get ready to use it, is not available or no longer the person is there. So I think within our EDs, that's our right now is our educational moment, is to say, yes, okay, the member is on the ALT. We first had to teach them what it meant when they ran the name in the system and saw the banner, and then who to contact. And so I think that's a positive for us.
Great. And I appreciate your candor on that. This is a new process for most community mental health organizations, and it is not going to be without bumps and hiccups along the way, but again, it's encouraging to hear that progress is being made. And I hope that staff who might be watching this from EDs can actually hear that as a point of encouragement. And so, kind of turning the same question over to you, Jenny, what have you heard from Hurley or McLaren? What what effects have they maybe seen regarding your AOT program?
Yeah, so before our program started, there was just a lot of questions sometimes, they would have a pickup order on somebody and why are they here? What is going on? The pickup order does not give them that clinical information as to why it was ordered. So the AOT program has given them more information because things don't automatically get put in the chart if it happened 2 hours ago and we went and asked for that pickup order, So to have that contact person to say what is currently going on with this person, because we don't want to send them home if there really is a reason to admit them and the person just isn't telling us what actually is happening for whatever reason. So the increased collaboration between the two of us to really get our consumers their needs met. We talk about, well, this person doesn't meet medical necessity for needing to go to the hospital. Like Sojo said, like what other services could we maybe link to? And we talk about what outpatient services to put in place with that person. We have had it come from the other way, not just us referring to the ED, but also the ED referring to us. So, hey, I have this individual who keeps coming to us and they're constantly in crisis, but they don't yet meet criteria for needing hospitalization. We'd like to look at getting an AOT on the person. Can you help? So sometimes they'll fill out the petition and, we'll have our doctor do the assessment for them and do the testimony, and just kind of working together to get the people in our community's needs met in the best way. And from having this open line of communication from both sides saying, these are my barriers and this is what I need. Can you help me with meeting, meeting those needs, or can you help me with this barrier that I might have?
Interesting. That kind of leads to my final question today, which is what have you specifically done to increase that collaboration? I know community mental health organizations have relationships with EDs. Usually there's a point person, but it sounds like maybe you have to go a little bit beyond that to really make AOT work. What does that look like for Genesee?
Sure. So what we've established was kind of almost a face sheet with our pickup order. So anytime that we get a pickup, we give our hospital a copy of the pickup order along with a simple face sheet that just kind of says, this is the case manager's name, this is the case manager's phone number, any other people that they might need to talk to about that. And then a really quick snapshot of why we asked for that pickup order. So then they get this kind of almost a face sheet with their pickup order, snapshot of what's going on. And then if they have further questions, they have, the exact person to reach out to, whether that be one of the AOT monitors or the case manager. And then there's a lot of times too that it's just picking up the phone. So I have this situation going on. This is kind of sticky, or I don't know what to do. Can we talk about it? So a lot more phone calls with one another, emails with one another, to come up with better processes. One of the things that we've done in Genesee County was having, when the hospitals have done a petition insert for people, we created this AOT addendum to petition form that is kind of a checklist of what outpatient services we're wanting to have in the court order. So if somebody waives those services can be reflected on what they waive, and it has it gives the attorneys, this is what the petitioner is asking for you to have. Do you agree to this? Do you want to go to a hearing? It just has more information. Previously, when the hospitals were doing those petitions, they weren't including that information. So we were getting orders that kind of were bare bones and weren't really what the consumer needed. And so that was another way that we kind of increased the collaboration and got orders that had more more of the picture of what the person needed to have court ordered than just medications.
So, Joe, wondering what efforts are underway in DWIN around that collaboration.
Well, in Wayne County, like I stated before, we have the wonderful opportunity of having one judge hear all these cases. And so he has also engaged with the emergency departments and the inpatient facilities. He has also made himself available to say, hey, if you have any questions, contact me. We have the behavioral health unit, which is the entity that monitors and oversights. And so Christina Morgan also has great communications and contacts with the EDs and inpatient facilities. And then you have myself. I'm old school, so I go to the ED if needed. I like to be hands-on. And when I go, it's just not for those persons who may be on an ALT. I also make myself available to be able to help with other those who may not be on an ALT, to get either a higher level of care or divert them to outpatient and link them up with services. And so I think that collaboration of, truly, I'm not just here for an ALT person, I'm here to help. And since I'm here, what can we do? Having those ongoing communications, we have a bi-monthly hospital liaison meeting with all of the EDs and inpatient facilities, and I'm constantly updating them, educating them, and having them get on board with this pendulum shift, because that's what AOTs are, is a shift in how we normally do things. And then also with deferral conferences, I think deferral conferences have been a missed opportunity for our members, for the EDs, if the person is still in the ED or inpatient facility. And so I believe that is the biggest amount of feedback that I get a lot of times with the inpatient facilities, is having that trifecta of their attorney, the member, and someone from the CRIS to say, hey, because the inpatient facility, they don't know what to order. And so they'll say, well, I think probably is best, really don't know. Where when you have someone who is actually the provider of treatment, they can say, well, in the past, this person suffered from this. I think they'll benefit from it. One of the things that I rarely talk about is medication, because, our members, that's a taboo. You want to get into a fight real easily, you talk about medication. And so I really try to focus on what brought them there and how can we make sure they don't come back. And again, building that rapport early helps so much for so many of our members that's in crisis or just don't know how they even got to this point and don't see a way out. And so I think, again, showing up, I know we're in this tech world and we're short staffed and all of that. But for me, the biggest piece about collaboration, I can't just come and get what I need. I have to be able to offer something to them. And so I think, even though they probably don't want to do anything, but because I come in and assist, they almost feel compassion to see that what I need is getting done. And so, but again, I think ALT is probably the epitome of collaboration. If you had to look it up, that's what it is, because you can no longer operate on an island of your own. It's very lonely there for our members and for the profession. And so to bring all parties to the table, to say, okay, well, what are you going to do? How are you going to do this? And really become solution focused. I don't want to hear about short staff because I'm doing 30,000 things and it's just me without a pay increase. And so what can we do now? And I think that helps everyone out when we stay solution focused.
Last but not least, Dr. Field, what types of collaborative activities has Summit Point been doing to help bolster this AOT process with EDs?
Yeah, I think for us, the biggest challenge as we had discussions and conversations with our ED physicians and the behavioral health providers working in those EDs, for them it was, how do we develop the recommendations when we don't know the customer that well? And so really building those pathways for them to communicate with us so that when we do a petition, they know about it in advance. There's a warm transfer process when a petition gets filed, that the ED is given advance notice of the customer coming and what we were thinking. So why are we doing a pickup order? What's the plan of care? Are we thinking they're actually going to need this, or is this part of a process that we're implementing, potentially utilize a black robe effect, or to really facilitate some other options in care for the customer? The other piece that we do, because like you said, when they're on the inpatient floor, they also don't have great visibility to what the service arrays are going to be post discharge. And so we have our hospital liaison very closely tied into the deferral hearings. That workflow, all of the court paperwork goes through us as opposed to being with the hospital itself, so that we can help structure that and give that direction and feedback. We have 2 hospitals in our county, and in one hospital we have a very tight, very close collaboration. We communicate regularly about what we're doing. We make improvements to our system. In the other hospital, we have a little bit more of a distance relationship in terms of how we engage and participate. And what you see is just the way that care is facilitated for those 2 partners is just a little bit different. But what we're really trying to recognize is that the EDs already have a lot in front of them, and that our job, in coordination with the court, is to be a buffer at the entry and at the exit, so that they can really focus on their crisis-oriented care, and they can hand off in a warm way as opposed to just a referral form. That's been critical. And so it's just continued communication, meetings with all parties present, and just having standing opportunities to walk through our process and just have visibility from each of the partners to who's doing what and how is it helping the customer. The biggest thing that I think we still find struggle is in our community-based program providers is, what is an AOT and how does it work and what can it actually do? And it's not as clear cut as it might be perceived. It's written in law, but it's not that simple. And so I think that's been the biggest benefit of the collaboration, and what we're doing is just continually pushing information, sharing, and walking through it with people hand in hand, as opposed to just saying, here's our new rules, we'll comply with them. That's been a big benefit in a way that we've been intentional in our collaboration with each of the steps in the process when a customer does utilize the ED, does go inpatient.
Great. Well, I appreciate all of our panelists' time this morning and just the opportunity to be able to discuss this matter further. I'm encouraged by all the great things happening out there, and I hope that our viewers can also find encouragement. And if they're not already engaging around this topic with their local community mental health, hopefully this can help prompt them to do that. Thank you, everybody, for tuning into this webinar. We hope that you found it valuable.
Thank you.